All right, let us talk about thyroid hormone. So thyroid and the thyroid gland. As I mentioned earlier, the pituitary gland sends out messages to the thyroid hormone or to the thyroid itself, and then the thyroid kicks out thyroid hormone. That's how that works. So there's a secondary, the thyroid needs a message, and then it kicks out thyroid hormone. I'm going to share my screen so we can move into this. So thyroid problems, what the big darn deal about thyroid is it's your metabolism, and it's a sympathetic nervous system stimulant. So that thyroid stimulating hormone that gets released from the pituitary gland makes the thyroid release thyroid hormone, and thyroid hormone influences metabolism and the sympathetic nervous system. The sympathetic nervous system is that fight or flight or freeze system, not the rest and digest parasympathetic. Sympathetic is fight, flight, freeze. So there is a continuum. So if you are set in neutral, they consider that eurothyroid. That's neutral. So people without any problems with their thyroid are euthyroid. So if you're not getting enough thyroid hormone being released, you'll have hypothyroidism. Eventually, what will happen if it doesn't get taken care of is these people will go into a coma. Like, that's how tired you get with hypothyroidism. You kind of turn into a sloth and then you go to sleep. So these people are very tired. They don't have a lot of energy because the thyroid hormone isn't coming out to help their metabolism. So it's not just that they're like tired, like I could use a nap because I didn't get enough sleep last night. They are tired because they don't have cellular metabolism going because they don't have thyroid. They have no metabolism. They don't have any thyroid. On the other side of the coin, you can have hyperthyroidism. Now, hyperthyroidism sometimes is referred to as Graves' disease. And if you have too much thyroid hormone, you can go into this thing called thyroid toxicosis. And we'll go into that when we get into hyperthyroid here in just a sec. But people who have hyper are hyper. They have a lot of metabolism, they have a lot of energy, they're burning through a lot of calories. People who have Graves' disease, who are in that hyperthyroidism like sort of state before they get to thyroid toxicosis, they will actually be able to eat like 6,000 calories a day and still lose 5 pounds a week. It's bonkers. So you can have hyperthyroidism where they're ready to rumble and they're really, really active and they're really going all the time and they're not sleeping very much. And in all honesty, some people might, like, from the outside, it kind of looks like somebody who has a bipolar problem rather than a thyroid problem. So one of the first things we check whether you're having, like, you're eating all the time, you're not sleeping very well, but you're really okay, and you're or you're having these sort of sloth times where things are really slow because your metabolism isn't working very well. One of the first things we do is we take a blood test to see how your thyroid stimulating hormone and how your thyroid hormone are doing. So we'll get there, but let's talk a little bit more about hyperthyroid. So hyperthyroid manifestations, these people, because their metabolism is going like, let's say it's going a solid 90 miles an hour, right? Not to the point of getting like a hugely bad ticket, but a bad ticket, 90, 95 miles an hour. They're hot. They could be walking around in a t-shirt and shorts, and it's January and they're still fine. They will have, if you look at the lady in the middle here, she has a couple different symptoms and manifestations of hyperthyroidism. You see how her eyes are just a little bit more bulgy than what we would expect? That's called exophthalmos. Exophthalmos is a bulgy eye thing. If you also look at her, she has this noticeable kind of like thickening of her neck right here, and that's called goiter. So her thyroid is enlarged. You can also have digital clubbing and swelling of the fingers happening with people who have thyroid hormone. But basically they are ready to go. When we get to this area where 95 still isn't fast enough, we can end up what's called thyroid storm or thyroid toxicosis. And so we'll have excessive amounts of thyroid hormone released. It's a life-threatening emergency. Basically, people are like burning up from the inside. Their metabolism is going so fast that their body can't handle it. So they've moved from 95 mile an hour range, right around here, like 300 mile an hour range. It's a life-threatening emergency. Death is rare if we can get the treatment started in well enough time. It usually results from a person who like normally has hyperthyroid, and then they get stressed out, and then their thyroid, because usually when we're stressed out, we need more energy, right? So we have more thyroid hormone, and we're like, okay, I need a little bit more to get me through this. So those extra stressors will pop a person into thyroid toxicosis. People who don't have a thyroid, when they're getting that or partial removal of the thyroid, they are at risk for increased thyroid toxic crisis or thyroid toxicosis or thyroid storm. So, like I said, these people are going 300 miles an hour in terms of their metabolism, and they're like combusting from the inside. They have severe tachycardia. That heart rate is going so fast and so hard that the heart will stop because it just can't do it anymore. Like it just gives up. This can create shock, hyperthermia. So they'll be running like 106-degree temperature, which pops their brain into a different, like that's the wrong temperature for the brain. So then they get agitated really easily. They'll have seizures. They'll have delirium. In addition, they'll end up with abdominal pain, vomiting, diarrhea. And then eventually, if nothing is done as an intervention, they end up in a coma because they have burnt up all of their stores. There's nothing left. And the body just collapses. There's nothing left to do. For diagnostic studies, so what will happen is these people don't need the pituitary glands, like, you do not need my help. As a matter of fact, if I could get you to slow your roll, I would, but I can't. I don't have that, so I can't. But you will have decreased thyroid stimulating hormone because it just isn't, it's not needed. You will end up having increased free thyroxine, free T4. You will have a total T3 and T4. It's looked at, but it's not very definitive. And so what people end up doing is taking a little bit of radioactive iodine to help people, to help the team distinguish whether they have Graves' disease or other sorts of thyroid inflammation, thyroiditis. Interprofessionally, our goals are to block adverse side effects of thyroid hormones, suppress that hormone, that extra TH secretion, prevent complications. So there's 3 primary treatment options. We can do anti-thyroid medications. We can do radioactive iodine therapy. So radioactive iodine is both used as a diagnostic and it's also used as a treatment, depending upon the levels and depending upon what kind of radioactive stuff we give. And then there's surgery. So for drug therapy, there is, it's usually only really effective in thyroid toxicosis. It's not very great in hyperthyroid situations, and it's not considered curative. So there is anti-thyroid drugs, iodine works, as well as beta adrenergic blockers. So those beta blockers can be used to more anti-thyroid drugs. So There's drugs that inhibit thyroid hormone synthesis. And I'm having problems saying synthesis, so let's go through this. Propylthiouracil and methimazole. So propylthiouracil is its own med. Methimazole is a different med. Both of them inhibit thyroid hormone synthesis. Usually improvement takes 1 to 2 weeks. Overall results are seen in 4 to 8 weeks rather, and the therapy lasts for up to 15 months. You can also do an iodine treatment with potassium iodine and Lugol solution. And so what that does is it increases the synthesis of T3 and T4, blocks the release into circulation, decreases the vascularity of the thyroid gland. So if you decrease the vascularity, you're making the blood vessels smaller, so your thyroid gland isn't getting as much nutrition and it's not as big. If we can minimize the size of the thyroid gland, the surgery is safer and easier. And because this iodine, it has a nice effect within 1 to 2 weeks. Beta blockers are symptomatic relief of the tachycardia, the nervousness, the irritability, and the tremors, because they're blocking the sympathetic nervous stimulation. So thyroid hormone influences the sympathetic nervous system. So if we can act on the sympathetic nervous system through a beta adrenergic blocker, then we can help the symptomology. It's not helping the actual cause. It doesn't help the thyroid hormone. It doesn't help the thyroid itself. What it does is it acts on the sympathetic problems in a different manner. So propranolol is used a lot. Atenolol is used a lot for people who are taking beta adrenergic blockers for hyperthyroidism. You can also have radioactive iodine therapy. So radioactive iodine therapy is a treatment of choice for most non-pregnant adults. It damages and destroys the thyroid tissue. And what it does is it's a non-surgical way so that they don't have a thyroid anymore. It can take up to 3 months for that radioactivity to destroy the thyroid tissue. The nice part about that is we don't have to worry about removing the parathyroid glands when we're doing that, because all we've done is we've taken and put the thyroid gland out of commission through radioactive iodine. The parathyroid glands are still intact. There is a delayed response of up to 3 months, like I said. It's given on an outpatient basis. So this basically, they drink a really awful tasting solution. And then we go into chemotherapy precautions because they have radioactive solutions. So they have to flush twice. They should have their own bathroom. They should have oral care for any sorts of, because the thyroid is here and the parotid glands are here. And the parotid glands have a lot of salivus. That's where your salivary glands are as well. So that's where you're making your spit. So you can have really dry mouth when you have this. People will, we need to talk about how to do oral care when we have impaired salivary glands. And then surgical therapy, there's, you can either go total or subtotal. The reasons why we do this instead of the radioactive iodine cocktail is if this gland is getting really big and it's starting to impede the airway, we don't have up to 3 months for the radioactive iodine to take care of the thyroid. We need to keep that airway. So we'll take that thyroid off. If the person's unresponsive to anti-thyroid therapy, if their thyroid cancer, if they're not a candidate for radioactive iodine. Remember, pregnant people can't get radioactive iodine. So if a pregnant person was to get to develop thyroid toxicosis, we might have an emergent thyroidectomy. What this does is it rapidly reduces T3 and T4 because there's no thyroid left to give it. You can also have a subtotal thyroidectomy, which that's the preferred one. So we'll take out 90% of the thyroid and leave part of it, so then they still have some parathyroid glands for calcium regulation. And it's minimally invasive procedures. So if you've ever seen a person who has just a little scar, like right there, right between their clavicular notch, or just above it right there, they've had a thyroidectomy, but the thyroid itself is pretty squishy. So we just need one little hole, and they end up removing it through that little hole. They can either do it endoscopically or they can even do it robotically. So here's a quick picture of a subtotal thyroidectomy. Nutritional therapy, while the people are going through this treatment, remember, they are going through like a bajillion calories. Like I said, they could be eating 6,000. They're eating tons of, like, their body is burning through tons of calories a day. So these people are going to be on like almost what a bodybuilder would be on, 4,000 to 5,000 calories per day. So 6 meals a day with snacks in between. Like, this is more than J.R. Tolkien, like the Hobbits. Like, they have first breakfast, second breakfast, 11sies. Yes, they're having first breakfast, second breakfast, 11sies, lunch, and then whatever else came after that. We want to make sure that they are getting lots of protein and lots of carbs and trying to keep the fat at a reasonable level. We want them to avoid highly seasoned and high fiber foods. They don't need no caffeine. Their body's running high enough as it is. And the best person that we can bring into the team for this particular type of client is the dietitian. So with that, I'm going to stop here. And I'm going to make some more video about nursing management of the client with hyperthyroid in just a moment.